Hello, everybody, and welcome back to Living Beyond Breast Cancer's 2020 Conference on Metastatic Breast Cancer. I'm Kathy Ormerod. I'm the Executive Vice President for Strategy and Mission at LBBC, and I'm thrilled to have you with us today. Before we jump into the program, I really want to acknowledge the sponsors. We have Forward for Toby as our lead sponsor. We have Athenex Oncology as our title sponsor, joined by Novartis and Pfizer Oncology. Please be sure to visit all the other sponsors. They're in the exhibit hall, and if you visit each and every one of those exhibit booths, you'll be automatically enrolled to receive a raffle prize, so please do that. I also want to take a minute to give a shout out to the lounge section and all the meetups happening there. Connections are being made, and we are thrilled as an LBBC staff to see that. One of the most gratifying things for the Living Beyond Breast Cancer staff in our in-person programs is to see people meet each other, to hug each other, to share contact information and become friends. And so it's great to see a lot of that happening there. Also in the chat room here, please be sure to connect with one another. And there's a Q&A button that's either at the bottom of your screen or at the top of your screen, and you'll be putting your questions in there. So I just want to take a minute to say yesterday we had incredible attendance, and this conference always attracts people from the US and Canada, but I'm told by our partners that we actually have people from 29 different countries joining us. So a special welcome to you. It's great to have you here. So I have two things I want to ask to you before we get going. The first is, if you're able, please go to lbbc.org and support our metastatic programming. You'll see a giant spice-colored, some say orange, button in the corner that says donate. Please click on that and help support us and programs like this one. And we are almost at 10,000 in our Instagram following, so we really need your help in getting over that mark. So please join us on Instagram. So I'm serving as your moderator today. As I mentioned, there is a Q&A button. Please put your questions there. And also you can chat with each other on the side. So let's get on with it. We have a great friend to LBBC, Dr. Don Dizon, who is joining us for this workshop. And Dr. Dizon is the Director of Women's Cancer at the Lifespan Cancer Institute, the Director of Medical Oncology, Rhode Island Hospital, and he is a professor at Brown University. So if you'd like to read more about Dr. Dizon's incredible biography, please do so on our website platform. As a reminder, when you are framing your questions for Dr. Dizon, he cannot answer your personal, he cannot give you personal advice. So please try to keep your questions more general. So Dr. Dizon, welcome.
I'm really happy to be here. I always look forward to doing work with LBBC, and I hope the presentation I'm about to give is going to be useful to all of you. So I was titled Living Well, Managing the Symptoms and the Side Effects of Metastatic Breast Cancer. And I always like to begin here because it's still a fairly ubiquitous thing to use cancer as something that describes a person. And there's a very grassroots movement that I've been involved with, and there are certainly some key opinion leaders within breast trying to change this. But just remember, for all of you, that we know as well, cancer is a noun, and it should never be used in an adjective to describe you. And most importantly, it should never define you. And I think that's important, especially because when you look at the literature, it is exceptionally common for you and your voice to be depersonalized. And that is something that you should not accept. The other thing that I always want to mention is this term survivor. And I know it's a loaded term, particularly for men and women living with metastatic cancer, and especially in the metastatic breast cancer community. But when I use survivorship, I really adhere to this one from the National Coalition for Cancer Survivorship. At its origin, survivorship was defined at the time of diagnosis and was technically relevant for the balance of one's life. It also went beyond the individual diagnosed with cancer, and it included family, friends, and caregivers. The reason that's important is because cancer is not something that one experiences in isolation. When, as I'm sure all who are here who are living with metastatic disease or not, when cancer enters into a family, that entire family is affected. And in the end, cancer is a social disease, and so is survivorship. So I would love to see the day when we reclaim survivorship for far more people than those treated with curative intent. The other thing that comes to mind as well when we speak about metastatic breast cancer is this term of near normal. It's a term that has been used when we describe after treatment, after curative intent therapy, when a woman or a man is trying to develop his or her sea legs again after undergoing chemotherapy and the initial treatments of breast cancer. I would suffice to say that I have learned from you. Living with metastatic disease means never having a normal life, that never achieving that sense of normalcy, never achieving that sense of stability where you go forward knowing things won't get worse. But there are things in that new normal for women who are treated with curative intent that I argue with my colleagues are still exceptionally relevant for women and men in the metastatic breast cancer community. There is still this fear of progression. And for those of you in remission from metastatic disease, it is truly that fear of recurrence. There is still challenges with body image. Maybe it's because you're on taxanes for a long time and the hope that one would get their hair back is a distant memory then. Maybe it's because the chemotherapy that you are on and continue on have changed your metabolism and you struggle with weight despite the fact you are trying desperately to lose it. There are still these challenges with body image that are not restricted to women and men treated with curative intent. There are changes in intimacy and sexuality, which are highly relevant in this community. And it saddens me when the only way people get to the clinic I run on sexual health after cancer are when they self-refer. So again, this is something that is relevant. It doesn't matter really where you are in that cancer journey. Then there's living with side effects. Again, a longer term problem, especially if treatment never stops. Balancing that with this maintenance or this desire to still be healthy, even if you're living with metastatic disease. These are not contradictory concepts. One can strive to live a healthy life and still live with metastatic disease. So we need to see you in that conversation. We need to include you in those efforts, looking at exercise, looking at diet. There is also worry related to finances, which is a big struggle for everyone. And some data presented at the American Society of Clinical Oncology meeting last year will speak to that. And then finally, for those who are parents, there are issues with childcare and how to be a parent in the face of unknown. And for those of you who are diagnosed early on in life, there may be that desire to be a parent, which it still is a very much an unspoken conversation. So let's go into a little bit of these into a little bit more detail. So fear of progression is as real as fear of recurrence. What we know about fear of recurrence is what I'm showing you on this slide, that it tends to affect patients who are younger, those who are parents, those who have very limited social support, and those diagnosed with higher stage disease, stage 3 or de novo stage 4. But more importantly, regarding fear of progression and then fear of recurrence, is realize so much of that impacts your caregivers. I have heard many, many caregivers, husbands and wives, who suffer in silence because they need to be strong. Just recognize that that journey that you might be on with metastatic disease is something that your caregiver, your lover does experience. All right, so here's the importance of knowing about fear of progression and fear of recurrence is that it can be, you can actually do something about it. And there's been an ongoing literature about what we can do for people who are struggling with it. This is one example that was published that was actually presented 3 years ago at the American Society of Clinical Oncology. It looked at women and men with breast colorectal cancer and melanoma who on a standardized questionnaire had very high fear of recurrence scores. The intervention was just counseling and the comparator was relaxation. And what they saw was that fear of recurrence can reduce, that fear of recurrence can be successfully intervened upon. And those interventions can last for a longer time than just during the treatment. So this conquer fear, what was it? And as I looked through this, realize that so much of this is relevant also for those of you living with metastatic disease, because it is about accepting uncertainty, controlling worry, choosing where to focus your attention, and defining the focus each day, and then adopting a sensible strategy to go forward. In Conquer Fear, it was really around screening and how often do you want to be tested? I think for women and men with metastatic breast cancer, you can adapt also into how you want to be followed with metastatic disease. Is it more important for you to live every day with the best quality of life you can, in which case you may not be interested in having imaging every 2 or 3 months. But if you know yourself and you know that you get benefits from knowing the cancer is not progressing, those are conversations that you can actually control with your physician. So again, evidence that interventions, not pills, mind you, but psychosocial support can really be of help to you. In terms of body image, recognize that time is your friend. And I think this is also something that is highly relevant after one is living with metastatic disease. Again, this is a study that was called the Restoring Body Image After Breast Cancer Study. And the bottom line is they took almost 200 women, again, did a psychosocial intervention compared to standard of care, and showed that just being around your group, those people who understand what you're going through and share that experience, can be very helpful in terms of accommodating a new view of who you are today. Again, here it was looking at identity, looking at a self-schema, how you define yourself in your life based on your community, based on your role in your life and in the lives of others, and then how your self-esteem is shaped, recognizing that there are both societal as well as cultural contributions to how we all see ourselves in the society. In terms of sexual health and intimacy, recognize that you have a right to be sexual. It is one of the activities that defines human nature. And it's one of the activities that only one person decides is not important, and that person should be you. When I say sexual health, it is not about activities specifically. It is the whole biopsychosocial experience, ranging from intimacy and arousal to desire, climax, and then satisfaction. This is your right as a human being. It doesn't matter if you do or do not have metastatic disease. You should access support for that because there are ways we can help. This is a slide that summarizes everything available, and you'll note that these are referenced, that these are actually data-driven recommendations, particularly for menopausal symptoms, sometimes called the genitourinary symptoms of menopause, or GSM. There's a syndrome of vestibular dyspareunia, that is pain on initial vaginal penetration. And then there's pain during penetrative sex with thrust, called vaginismus. These three in particular do have interventions available. These three in particular should be available to you if this is an issue. But not to belabor the point, intimacy is also exceptionally important. It is a key component of relationships, and it's a component of well-being as couples grow and change, especially during metastatic disease. Enough data shows that a relationship can help buffer those severe life stressors that you might be experiencing on an occasional or intermittent basis, whether it be looking at a new CT scan or deciding on next steps to disease. But what's even more important is that there's a growing body of literature that cancer not only has an impact on the relationship and that intimacy can help adapt, but that one can actually develop intimacy as a primary endpoint to a satisfying sexual life. That I have recognized that activities, particularly for women, are not important aspects of their sexual health. That intimacy can be met without engaging in any action, and that we can encourage couples, particularly where penetrative sex or sex in general is not desired, that intimacy can still be achieved. This is an area as well, fertility, that I think is also relevant for women with metastatic disease. Why is that? Because not everyone's story is the same. There are women who will be alive for years, and there are women who may not be. But not everyone is going to have the same experience walking through metastatic disease. Now, I am not suggesting if you're a young woman, you ought to get pregnant because it's your right. What I am suggesting, there should never be a question, there should never be a topic that you feel you cannot discuss. There should never be a topic that is taboo when it comes to your life. And if you remember, there was a beautiful book, When Breath Becomes Air, by Paul Kalanithi, a man, a neurosurgeon who developed brain cancer and got his wife pregnant after his diagnosis and had a child and died during that child, shortly after that child was born. Now, I always wonder what would have happened and would that book ever be written or even read if Paul was a woman, if she had metastatic breast cancer and said, my last wish is to have a baby. Would the medical community be supportive? Would your parents, would your friends be supportive? This is a very, very tough conversation, but I will encourage you to have it because as we've learned with the fertility in women newly diagnosed with breast cancer, having the conversation is so important to not experiencing regret. Because parenthood can be possible even if one is not able to carry or have a child naturally. Adoption is open. However, there is discrimination. If your metastatic breast cancer is being coded as terminal, then that will fish that specific word, that very phrase may exclude you from any process of adopting. Surrogacy is also an option. However, there are practical aspects of this, legal aspects and financial. And I should know because I had my kids through surrogacy. So if this is an area of interest, I'm happy to speak about that. Healthy lifestyles is also something that I want you to feel you have a role in that conversation because heart disease is still the #1 killer of women. And we know walking at least 9 hours a week lowers the risk of bad outcomes. And there is emerging literature in cancer that adopting a healthy lifestyle has prognostic impact after a diagnosis of cancer as well. The one issue that we are really trying to do much about is the opportunity loss and risks to financial health that comes with a metastatic breast cancer diagnosis. Women who are diagnosed with metastatic disease can be as young as 19 and 25, as well as older into their 30s, 40s, and 50s. Oftentimes, it can strike people when they are starting in their careers, starting to make their lives, and also mid-career. And then all of a sudden, they are looking at changes of their life and threats to their financial aspects. We understand this is real. This is data from ASCO 2019. It was a survey of the Metastatic Breast Cancer Network, over 1,500 people, and 35% reported they were uninsured. When you compare that uninsured population to those with insurance, 98% of those without insurance said they had delayed treatment or refused it due to cost. 40% said they skipped paying medical bills because they couldn't afford to. 65% of those who were uninsured reported having stopped work after their diagnosis, and 77% were contacted by collections agencies. These are all significantly higher when compared to women with insurance. But this is not to say that women with insurance experience no issues, because of those with insurance, when you compare them to without insurance, they reported significantly more emotional distress related to costs and reported significant familial stress because of it. So again, insurance isn't the equalizer in this equation. Treatments are expensive, and they're getting more expensive, particularly as we seek going towards more targeted treatments, going more trying to get more treatments for women who've been excluded from clinical trials, just like those women with HER2-positive metastatic breast cancer. New drugs are expensive. This will become a bigger issue, and we need to help. So here are some recommendations that you can do to protect or react to cancer costs. If you don't already understand the language of your insurance company, of your plans, understand what's covered, what's a benefit, reach out to the business office of your institutions and the financial services. Take stock of what's important in your life. We are already doing that in the era of COVID. We are cutting back on things we can do without. I think probably women and men with metastatic breast cancer could teach the world a thing or two about taking stock. If employed, talk to your boss about options of the remaining employed, even as you have or may experience difficulties with keeping up with a full-time job. Talk to your social workers, keep a record of your expenses, and if you're at an institution or getting care and receiving bills that you don't understand, ask the questions. And finally, a thing to ask your doctors as you move forward who are recommending multiple tests and you're not sure why, ask them why they're ordering it. That is not in any way an affront to anyone's medical judgment, but we in medicine are under the edict to choose wisely as well, that we need to choose the tests that are going to make a difference. And if you don't understand why a test is being ordered, ask the question. So how do we all move forward from all of this? The first is educate yourself. And I'm going to show you screenshots from Twitter that I just picked up and from people I've learned from greatly. So here's Dr. Kelly Shanahan, who's a very experienced patient advocate and also a voice within the community who shares the role of physician and patient as well as advocate. And here, she is not shy about reaching out. If there is data that is being presented, regardless of the forum, you have a right to be in that conversation. The conversation concerns you or it concerns your loved one. This should not be an intimidating thing. And remember, none of us in oncology ever expected any single patient to come in with a new diagnosis knowing how to do oncology. I studied for 3 years to do this, and I'm 20 years in this field and I am still learning. So ask and learn, understand your cancer, and with that, engage. All of you have a story to tell, and those stories are important because there is someone out there who may or may not have a network. So tell your story, whatever the forum is, and know that someone is looking. Even though I write quite a lot, I have to tell you, I don't write to be read. I write because it's therapeutic to me, and it's nice when people read what I'm reading. But it's also humbling when you hear what people take away from the things you put out there. Here's Susan Ron responding to Tori Gibbs' tweet about her story. These are important. None of you have a story that is boring. All of you have a story that is important. And remember that. With all of that, once you educate yourselves, once you engage and find your community, find your tribe, evolve, get involved in this movement, get involved in demanding more, and get involved in wanting better. All of you can make a difference locally, nationally, and even internationally if you choose to. Now, this is not a I'm not going to sit here and say all of you must raise funds for metastatic breast cancer. What I will say is all of you have a way to contribute. And that personal contribution is beautiful. Because together we can make things much, much better. And we can be heroes. And I do include all of you in this slide. So with that, thank you for having me. And please, if you're not already, follow me. And I'm happy to take any questions. Thank you.
Great. Thank you so much, Dr. Dizon. I really love your message. And if you have a chance to look in the chat button, many others are really appreciating this message as well. In fact, someone wants you to be Surgeon General in 2021. So there you have it. Getting information, asking questions, learning, having the right to be a parent or to be sexual are just some of the great takeaways I have. We have questions we have lots of questions already. People are really wondering, how do they talk to their oncologists or their healthcare providers, particularly about sex? It is not welcome and people are really struggling with it.
Right. I think that's a really important question to ask because as you are uncomfortable asking your doctor about sexual health, your doctor is probably not ready to hear the answers. So what you want to do is try to find a sympathetic ear. What I go around telling my colleagues, by the way, when I speak about sexual health, is I say, bring up the issue early. You know, we all take a medical history. We all do a review of systems. How many times have you been asked, have you had diarrhea? Is it watery? Is it solid? What color is it? How often are you going? Are you passing flatus? These are not questions you ask in parties, right? These are really quite sensitive questions. So is sex. So it's a really easy thing for me if I'm meeting a patient for the first time to say, sometimes people when they get diagnosed have issues with their sexual lives. Do you have that? And yes or no? Do you want to talk about it? If they say no, they're going to walk away knowing I asked the question. And I think knowing that I asked the question sets it up for a woman or a man to then come back to me a year later
2 years later and say, can I ask you about something? Because they know the door was opened. Now, if that door never opens, talk to your nurse, talk to a social worker, talk to your infusion team, talk to a nurse practitioner and just say, you know what, I have something sensitive that I need help with. And I think part of the reason why I think it's important that we start sexual health clinics across cancer centers is because some people, particularly again with metastatic disease, are so distraught from the lack of resources that they find the resources themselves. When I was in Boston, I cannot tell you how often women with metastatic disease found me and didn't tell their oncologist. And when I told their oncologist that I saw their patient, quite frankly, more often than not, the response was, oh, I didn't know you saw people with metastatic cancer. So there is this sense that if you're living with metastatic disease, the sole concern you should have is to stay alive and to be out of pain. That is a mistake. And we all need to recognize that. So if you do not feel comfortable talking to your doctor about it, don't do it. But find that person who has given you the support in your team. And short of that, find that support within your tribe.
Great. Thank you, Dr. Dizon. Those are great messages. Someone asked if you would, if you have a resource that someone could give to their partner about some of the sexual side effects to help educate their partner.
Yeah. Well, there's a great resource at LBBC that I actually helped craft, and I'm actually quite proud of it. We did do one specifically for people living with metastatic breast cancer as well. There are really nice books out there. Some of my favorites were written by Michael Krichman, or Krychman, and then also by Ann Katz, Katz. Ann wrote a book called Women, Cancer, Sex. It's a very nice book, and it's not written for clinicians. It's actually written to be read by people who need it. And the final thing I'll say is there's a really great resource online. It's almost a self-help program called Will, W-I-L-L, the number 2, and then LOVE.com, will2love.com. And this was put together by Leslie Shover with NIH funding when she was at MD Anderson. And it's a program that you go through with your partner, and you learn and you hear stories, and it's multimedia, and you set your own goals. So again, multiple things that are available outside of cancer centers, but also some resources for you to get started.
Great, thank you for that very helpful answer. In terms of personal intimacy, one of our earlier questions was about someone who's concerned that her death is going to impact those she loves, and so she holds herself back because she wants to protect people.
Yeah.
What do you have advice for her?
Yeah, so I'm going to preface this by something very personal, and I've shared this on social media, and I think several of you have expressed condolences, which I greatly appreciate. But I just lost my aunt to stage 4 lung cancer 2 days ago, and she was in hospice for about 3 months, and for the last year we knew things weren't going well. The one thing we did as a family was confront that together. There's a lot of fear around death, and there's a lot of fear, particularly for the person who might be facing that prognosis, about all the emotions of not wanting to die, not wanting to leave anyone behind, and then yes, not wanting to scare anybody. What I will tell you is take home the message around fear of progression and fear of recurrence. Everyone around you is suffering in silence, probably, And the reason they're doing it is because they are so invested in protecting you as well. They want to be the strong ones while you're trying to be strong for them. So there is always a conversation that could be had in quite a sensitive way. And I suggest, or I would love, that we all have those conversations in a very safe and protected way. And some of the conversation tools I teach couples around sexual health and intimacy may be relevant here, which is not to presume what other people are thinking or experiencing or feeling, but really to stay in the moment of me, my experience, my feelings, my thoughts. So telling your husband or your wife, I am so afraid of leaving you alone, that is your experience, and that is your suffering, and that's something that he or she probably wants to know, because probably he or she can also say, I am so afraid of losing you. And then there's really nothing wrong with both of you experiencing that moment, but there's no reason you should experience that moment alone.
Thank you. Please know there's many condolences in the chat box to you for your loss.
I appreciate that. I really appreciate it. Thank you.
Okay. Some people are wondering if the telehealth revolution that has happened because of COVID is available for some of the other services, not just seeing your medical doctor, but some of the psychosocial service. Do you have an answer to that? Is that emerging? What's happening there?
Yes, actually, when I was at the Mass General, all of my sexual health visits were in person for the initial consultation only. And then after that, we did everything via telehealth, unless a woman or my male patient wanted to see me in person, personally. So there are certain things that are really important to do in person that telehealth it just can't do. So if you are experiencing pain with penetration, for example, or if you're experiencing any burning or discomfort in the pelvis, that really does require a pelvic examination. And not at every visit, but at least for the first visit, just to see if we can, directly diagnose what's happening. Then after that, you can do a lot of things by telehealth. So during COVID, I was doing quite a few initial consultations via telehealth because there was enough guidance federally that allowed it. I don't know if that's going to continue. It's typically not, you cannot do that. And I was also doing telehealth visits across state lines. So I think that's probably here to stay, but for certain aspects, it just won't replace in-person visits.
Okay, so it's evolving and check with your healthcare system. Yeah. We have some younger women and other, probably, I'm not sure the age, but some are young in the questions, who are worried about dating and how to put themselves out there, and are wondering if you have any suggestions.
That is actually one of the biggest groups that I see in a sexual health visit. And the first few times, at the first visit, I should say, most women are so embarrassed to be seen at a sexual health consult because they're not in a relationship. And I think it is the most incredibly self-aware thing one could do, is to see themselves in a relationship when they aren't one, even if there's cancer in the picture. So I encourage women not in relationships to see a sexual health counselor, because I do think it's important. So what do we talk about? We do talk about safety, and I'm not talking physical safety. I'm talking more emotional and mental health safety wise. Some people are huge advocates in their community. Everyone in their neighborhood and their city knows they had breast cancer. And some women, it's their source. It's as natural to them now as it is that they are a Jewish or Black, for example, their skin color, right? They just had breast cancer. And that is just something that people will have to deal with. And they come to me with that perspective. If someone's going to date me, they're going to know I had breast cancer. But my issues are this, okay? Trust is an issue, and physical aspects of intimacy are issues. For women in whom the experience of breast cancer was private, that, they don't have a big advocacy background and they're not, locally active. And really, it was just something that they went through with in a very quiet way, because that's how they wanted to do it. For those women, we talk a lot about disclosure and when to disclose. And we even play out scenarios of, how are you going to meet somebody? Okay, if you're going to go and do online dating, what do you think? What are your thoughts around putting it in your profile, for example? Which most women, and I tend to agree, don't put it on their profile. We don't put on our profile that we are diabetics, for example. We don't put in the profile that, I have lupus. I don't think there's an expectation that a cancer diagnosis will go on one's profile. Now, say someone is hitting it off and things are becoming quite intimate, then I tend to see people, multiple times while they're getting to know a new partner. Some of it is just discussing navigation of intimacy as well as sexual health. Others of it are emotional, of preparing, the time to disclose a diagnosis, and then preparing oneself for reactions, whether that be, oh, this isn't important to me, all the way to, oh my God, you should have told me earlier, and having them run out the door. More importantly is, I tend to see people after that's happened, so that we can almost debrief and think about it in a way that is supportive. But to answer the question, there's no one right way to disclose, and there's no one scenario that women are walking in with those issues.
I know on lbbc.org we do have some programs about this very question, how to do that. So please be sure to check that. Switching gears a little, someone's asking how to involve palliative care in the care team, and how one really needs to actually advocate for it. And you've talked a lot about advocating for yourself.
Yes, absolutely. And so I think the weird thing, well, not weird, the unresolved issue for women and men living with metastatic disease is that palliative care early on is exceptionally important, in terms of the emotional anxiety of living with metastatic disease, dealing with the uncertainty of the future, and helping navigate side effects and minimizing toxicities related to treatment. They also are exceptionally important for spiritual guidance when it comes to this. And then also the goals and preferences parts. That is exceptionally important. That's palliative care. That's what's important about it. It's not end-of-life care. Some docs around the country still see palliative care as hospice care. So you might want to go and phrase it as, I really would like more supportive care while I'm going through treatment. MD Anderson did a really interesting study where their service was called palliative care, very few referred in. When they changed their name to supportive care, lots of people took advantage of the service. So let the name not hold you back. But as important is this idea that there are things in palliative care that are not met. And that's what I was getting at as well. If you're interested in doing a good diet, or if you're interested in an exercise routine, or you want to talk about sexual health and intimacy. These are things that we sometimes relegate to survivorship clinics, okay? Not to palliative care. I argue that survivorship needs to be blown up and needs to be rethought and needs to be named something else so that it doesn't matter where you are, you access the same services. And it's not beholden to you to find the service, because if we can blow up this idea of survivorship today, then I think there's a full gamut of supportive services that actually runs all the way from living well and improving quality of life, all the way out to symptomatic palliative care, and then ultimately hospice.
Great. Thank you. We have a question from a mother of 2 children, 8 and 12, and her children know she's in treatment, but they don't know it's metastatic, and she doesn't know how to tell them. Any suggestions?
There's a great website through Mass General called Parenting at a Challenging Time. That may be a nice resource to start. At Brown, we really do rely on our social workers to help navigate those very difficult conversations, with fear. What I've learned from my own panel of men and women that I've treated who do have young kids is that the kids know, even if they're not saying anything. I have a young woman currently who is in her early 20s and is in hospice for cervical cancer, and she has a young daughter. She used to bring her in all the time, and now she doesn't bring in her daughter. And I asked her about it, and she said, her daughter is just living in her social media world with her friends right now, and I like her right there. So I think, there are strategies that need to be employed, and there's just no recipe to do that. Every single person's situation is sensitive, and working on a way to bring in the family, to let them know what's going on so that it's safe and disclosed in a way that you can support them and that empowers you to continue that support at home is ideal. And I think I'd start with our social workers in your community. But if you look at the FACP program at Mass Gen, they may be able to point you towards resources as well. It's called Parenting at a Challenging Time. It's at the website at Mass General Cancer Center. So FACT, the PACT program.
Great. And I'll add to that, Living Beyond Breast Cancer has books for parents to talk to their children about cancer. It's called Reading for Reassurance, so please check that out as an additional resource. Another sort of disclosure question has to do with careers and work, and how do you disclose that you have cancer to your workplace?
So I think that's a really sensitive question. It's an important one. My advice is to engage in human resources as soon as possible, and not to delay that. And the reason is breast cancer management is pretty complicated. And I'm going to take the example of a woman with hormone-positive breast cancer for a second, who goes through surgery, may have enough sufficient risk factors that they need chemotherapy, and then after that, it's going to be endocrine therapy. Human resources is important because they can put that treatment plan into place so that they can help you manage the expectations. Okay, so if you don't tell your boss, or you tell your boss, I'm just going to have a bit of surgery and I'll be back. Okay, that's a very different thing, because he may be thinking, oh, she's probably an appendix or something benign, not realizing that's stage 1 of your treatments, that there's still going to be another step that's going to happen. And certainly, I think everyone who hasn't experienced breast cancer that went on endocrine therapy see the end of surgery or the end of radiation or the end of chemotherapy as the end of cancer treatment. And if you're on an endocrine treatment, if you're on an aromatase inhibitor or ovarian function suppression, or even on, an aromatase inhibitor combination, these are not benign treatments. They have side effects. And even if you're not, you are never free of the cancer experience because you are being seen every 3 months. And it's actually, I don't need to tell you that when you're being seen for metastatic disease, that's a whole different ball of wax. So the disclosure to human resources, I think, is a step that needs to happen early, because that's where you're going to get information about medical leave. That's where you're going to get information about options to stay employed. That's where you're going to find out your options of what would part-time look like. And that's also where you're going to get some information on, if I have to work at a reduced capacity, what do I need to do? Now, this is very different from telling everyone in the office. It's not a water cooler conversation about your breast cancer. It's more important that you do everything that you can as early as possible so that you have the option of staying employed.
Great, thank you. I'll just mention 2 other resources: Triage Cancer and Cancer and Careers is the second one, can be resources around this particular issue.
Yeah.
So we do have a number of questions actually about people's experience with fertility drugs and our concern that maybe the fertility drugs cause their cancer, and concern about that.
Yeah, so I think the bulk of the data on fertility drugs is that it didn't cause your breast cancer. So, at the end of the day, you are not to blame for your breast cancer. Even for women who had a BRCA mutation and didn't do a biomastectomy, you are not to blame for your breast cancer. We've seen a lot of women who lived a healthy life, had a baby at a young age, breastfed, vegan diet, yoga, the whole 9 yards, and still got breast cancer. There's really, the vast majority of breast cancers are still what we consider sporadic, or we don't know why you got it. But the data for fertility drugs do not support it as a risk factor for breast cancer.
Thank you. We also have a question about resources for non-binary patients. Do you have any suggestions?
Yes. I first off want to say that we in medical communities and organizations across the globe are just saddened and angered by the Trump administration's actions in taking away non-discrimination protections for non-binary or transgender individuals. There is an emerging, the sad thing I'll say about binary people with cancer, we don't know anything about you, okay? Very little data exists because we have not collected that data. 10% of clinical trials that are being done nationally are collecting gender data beyond male, female. And the addition of genders beyond male, female are not widely utilized. It gets even worse when you're trying to find information about transgender or gender non-binary individuals. When you even try to go through the medical records and you say, okay, well, let's try finding people coded as men and had ovarian cancer, to see and truly see if that is a transgender individual or a gender non-binary individual requires the documentation somewhere to state that. That also doesn't exist. So I am part of a group at FASCO working on gender. sexual orientation and gender identity as a task force, and I'm doing work with the LGBTQ Cancer Network about demanding more information about our transgender communities and what disparities they might be experiencing. What we've done with LBBC is we do have information on gay and lesbians and cancer, but I remember Kathy arguing that when it comes to the transgender community, this is not that conversation. And we really need to learn more. And I'm glad to say that nationally, we are finally making those efforts.
It's a start, right?
It's a start. That's all we have right now, yeah.
It is a start. We are getting to the end of our questions, and there are so many. Someone writes, and I have often hear this, people are very depressed and they don't like sharing about their depression, particularly around issues of metastatic breast cancer. You've spoken during this session how important it is to connect to others, to connect to those in the metastatic community. But what can you say to someone who's really feeling isolated?
Right. You know, I think what I've learned through my efforts in social media is that can be the lifesaver for so many people. I grew up on Guam, which if you don't know is in the middle of the South Pacific somewhere near Hawaii, the Philippines, and Japan. There was, you know, we didn't talk about cancer when I was growing up. So I never heard the word metastatic when I was growing up. So I can't imagine how isolating an experience it would be for anyone who had had it and was living on the island. But you don't have to be an island. And I think, you know, it's been so great exploring the world on social media to see how much support can be obtained out there. And I have to tell you, I've gotten referrals from around Rhode Island into Connecticut and Massachusetts because people reached out on Facebook or on Twitter and said, is it a problem that I haven't seen a surgeon and it's been 3 months since I've been told I had breast cancer? You know, I think there's strength in numbers. And the most important thing beyond that is that we know that isolation not only can make people just feel so alone, but isolation is associated with a worse prognosis. So with that said, you can create your own community. And if it's not there in the city or in the town that you're at, you know, a safe way to do that is to just look and see if you find a voice on social media that you identify with and create that community for yourself.
We are out of time, I'm sorry to say, but thank you so much, Dr. Dizon, for just a great presentation and answering so many questions with your usual compassion. Thank you again. Have a wonderful day.